Okay, everyone. Hello. It's 6:30, so we'll be sure to be timely for everybody tonight. On behalf of CEC Oncology, I'd like to welcome you to today's educational activity titled Advancements in Management of Relapse Refractory B-cell Malignancies, Integrating Recent Data into Practice to Improve Outcomes. Today's program is being put forth and supported by an educational grant from Lilly. And this is being brought to you, this program, like I said, being brought to you by Creative Educational Concepts. It's an award-winning accredited provider of continuing education for clinicians worldwide. This CE activity is accredited for 1 hour, and to receive your CME CE credit, please scan the QR code to create an account. Definitely don't leave these on the table. I've learned the hard way when I've come up for my 10-year evaluation, and all of a sudden I found that I wasn't participating in mock and not submitting my credits. So now I do that, and I left many of these on the table. So please do that. To ask a question, you can use the Q&A feature. We'll be monitoring those. You can sometimes people put it in the chat, but I think, yeah, just on this, I'm looking at it, we just have a chat form there. So put it into a chat. We'll be sure to cycle back to it, and I will address all of these questions at the end. And then you just have to note that this activity may include discussions of products and devices that are not currently approved for use in the United States by the FDA. And the faculty, me and others who've given this program have been informed of their responsibility to disclose that, and I'll note it where things are not FDA approved. And so this is who I am, and I'm an associate professor of clinical medicine at Weill Cornell in New York City. I've now been here on faculty almost 11 plus years doing lymphoma. I'm a lymphoma specialist. My research interest is maybe mostly in CLL, where I run clinical trials in that space, but I run studies in all disease states, DLBCL, mantle cell, other lymphomas as well. And those are my credentials to speak to you tonight about this topic. Here are my disclosures. Worked with various companies that are developing drugs in the space. And my other co-planner, a nurse practitioner, Amy Goodrich. These are her disclosures as well. So here are our learning objectives, and we want to implement treatment options for patients with relapsed refractory CLL based on the latest clinical data. We want to use evidence-based approaches for personalizing treatment for our patients with mantle cell lymphoma. And we want to develop team-based frameworks to oversee and address adverse events, prioritizing patient adherence and active engagement with our patients with these new drugs. We need to really be working with them and the whole team in order to provide the best, highest level of care. So here is kind of that pie chart where you might be familiar with looking at the non-Hodgkin lymphomas that are diagnosed in the United States each year. And, I always kind of like put it out there about 100,000 cases of non-Hodgkin lymphoma are diagnosed each year. Close to a third of those are DLBCL. So diffuse large B-cell is clearly the most common non-Hodgkin lymphoma out there. CLL is not too far behind, and it is there up there with follicular lymphoma in terms of the next most common lymphomas out there. In the SEER database, actually CLL gets taken out of the non-Hodgkin lymphoma, but nonetheless, we see about 20,000 cases of CLL diagnosed each year, which, the incidence actually is even higher than that because patients live a long time. And 5-year, 10-year survivals are now pushing out to close to 80, 90%. So the prevalence of CLL is about 200,000 plus, and that makes it a much more common disease. And it's one of these diseases that patients will develop, and then they actually start to identify patients and people and other friends and family that actually know people with CLL, and then it becomes this less isolating disease state. Mantle cell lymphoma, on the other part, is actually a rather rare disease, maybe 5,000 cases on a max SEER database year when they look at it. 3,000 to 5,000 cases diagnosed each year. It's this small pie chart that I'm pointing out there. I don't know if you can see my cursor or not, but only about 4% of non-Hodgkin lymphomas are MCL. And, while patients are doing better, this can be an aggressive disease. Fortunately, patients are doing better, and we do see, median PFSs of 10 years now with the frontline aggressive therapies that we're doing. So, patients can do well, but still relatively rare. And even though patients are doing well, the prevalence increases. It's still a rare disease, and we don't have tons of these patients to put on trials and to really do it. So we need unified efforts to identify the best approaches for these patients. So when we are looking at, so we'll focus on CLL first. And when we're looking at our treatment options, these are the NCCN guidelines, and this will be evolving in the near future with full approvals in this space. But in the first line setting, we've really replaced chemoimmunotherapy. We're no longer using chemotherapy. It is not the standard of care in the United States as the first line therapy with or without deletion 17p. It doesn't matter. And in fact, these targeted novel agents have taken over. And we really have BTK inhibitors, including acalabrutinib, zanubrutinib, and even ibrutinib. But when we're talking about preferred options, ibrutinib has been moved off of the NCCN guidelines due to toxicity issues. And in general, our prescribing practice in the United States has moved towards acalabrutinib or zanubrutinib as the first BTK inhibitor that we want to use. Either one of those, essentially they're equivalents, they're second generation, and have mitigated a lot of the BTK inhibitor toxicities. Venetoclax obinutuzumab is the second type of approach that we're using, that we were using, either a continuous therapy BTK inhibitor or a venetoclax obinutuzumab fixed duration approach. And then we're now starting to get into our doublet and our triplet options where we can use a BTK inhibitor, venetoclax combos. And the only one that's potentially going to be FDA approved in the near future will be acalabrutinib venetoclax or acalabrutinib venetoclax obinutuzumab based on the Amplify study. These have already crept into the NCCN guidelines, which helps us get access to these drugs before the approvals in terms of insurance approvals and getting them paid for and kind of used off-label. But they've been now almost 6-7 months, essentially, maybe even a year since they've crept into the guidelines. And so we're now using these approaches. We don't know who or how or which one to use for specific types of patients, and we view them all equivalent based on some recent data from ASH. But nonetheless, various approaches might benefit a specific type of patient or preference for their treatment, and therefore we're getting more and more data and information. It doesn't really change much if you've got higher risk disease, though there are some folks out there that believe continuous therapy BTK inhibitors are the best way to go for a high risk del17p complex karyotype patient. But fixed duration approaches are still very reasonable for these patients. We do know that they will relapse sooner once you stop their therapy. Subsequent lines, we just kind of flip what we used. If we used acalabrutinib continuous therapy, we do a venetoclax-based approach. If we use a venetoclax-based approach, we typically can either retreat or we can flip to a BTK. And if we use doublets or triplets, those are typically given as fixed duration, and the expectation is that you will have 5 or 6 or 7 years off of therapy before you need them again, and essentially it opens up all of these same agents at the time of relapse. So these things will come into play, but we do have pirtobrutinib now that is kind of getting, that is approved now in relapse refractory settings, and it's currently now FDA approved as of like a month or two ago, fully FDA approved after a prior covalent BTK inhibitor. So the initial accelerated approval, it's hard to keep these decks updated, was actually after covalent BTK and venetoclax. But now pirtobrutinib no longer needs the double exposure. You can just give it to a patient after a prior covalent BTK inhibitor. And then CAR T-cell therapy is still there on an accelerated basis after covalent and venetoclax-based treatment. Here are the various drugs that we're using. Nimtabrutinib is in clinical development. These four, the 3 covalents, and then the 1 non-covalent, pirtobrutinib, are the 4 FDA-approved BTK inhibitors. Nimtabrutinib is also a non-covalent BTK inhibitor that is in current clinical development and has big phase 3 registrational studies ongoing. So when you're talking about mantle cell lymphoma, it's a little bit of a different story. We still do have some incorporation of targeted agents, but we haven't quite gone completely chemo-free in these patients. But nonetheless, we think we can, and more data and trials are showing that we might be able to. There are kind of less aggressive induction regimens that you can do, acalabrutinib plus bendamustine rituximab. is an option. Sometimes you can give monotherapy BTK inhibitors, so that's not approved in the frontline setting. But we have these in our guidelines to potentially offer patients. In general, though, if we've got a young, fit patient, chemotherapy is still kind of considered the standard of care. I think that's arguable. I think there's camps where people are going to say, I'm not giving chemoimmunotherapy to any of my mantle cell patients. There's a lot of other folks that are saying, I'm giving chemotherapy, but I'm incorporating the targeted agents like BTK inhibitors. And so in general, the most of the patients fall in this middle stage here, classic P53 wild type, advanced stage mantle cell lymphoma. And in general, BR has historically been something that we like to use, but now with CAR T cells, we don't like to use BR as much. High-dose cytarabine-based regimens are typically a standard for our young, fit, aggressive patients. And the Triangle study, which is, again, not an FDA-approved option, incorporates the BTK inhibitor with the R-CHOP, alternating with the DHACs just alone, and then maintenance BTK inhibitor. And with that study, we've proven that you can get rid of transplant for consolidation for these patients. So we don't think we need to transplant our mantle cell lymphoma patients anymore. And then our highest risk patients, those ones that we know will not respond very well to P53 disruption, we're using, true chemo-free approaches, just like we do in CLL. These patients don't typically respond very well. And we're going with the Bovin regimen, which has got the NCCN guidelines here. Again, not an FDA-approved approach, but has strong data behind it and is in the NCCN guidelines. Maintenance rituximab is a mainstay in mantle cell lymphoma, whether you're transplanted or not. We have shown, even if you weren't transplanted, that there's still benefit and even potential overall survival benefit by maintaining maintenance rituximab for mantle cell lymphoma patients. So we do that whether you are after transplant or not. And then if you haven't had a targeted agent, or you had something and you're as a fixed duration, and you've got years in between a relapse, typically we are reaching for our BTK inhibitors in that second line setting, though we have IMiDs approved in this space. And then obviously after progression on a BTK inhibitor, that's where CAR T cell therapy comes in. That's where pirtobrutinib comes in. And now we actually have bispecifics in the NCCN guidelines that are trying to cross the threshold of getting full approval in mantle cell lymphoma. And we have CAR T cells here as well, by the way. So we'll focus on CLL, and we'll focus on a case base. It's always nice to be in the room with you when we talk about cases, but in this scenario, that's the post-COVID world that we live in. So here's a 59-year-old gentleman, hypertension, no other medical conditions, diagnosed with rise stage 1 CLL. Prognostic markers show normal FISH, unmutated IGHV, and P53 wild type. He's starting to progress. He's now age 62, and he needs frontline therapy for his CLL. He gets started on ibrutinib, achieves a PR, and was in remission for about 8 years. Now he's 70. He's progressing, and he's got a P53 disruption, and he's got bulky disease. At this point, he's resistant to a BTK inhibitor. He progressed on it, and appropriately, venetoclax-based approach was utilized and achieved a PR and with undetectable MRD. He got only about 2 years in remission, and then he is progressing and now has bulky lymph nodes again. So what are your treatment options? Essentially, you could potentially retreat, but is only 2 years off of therapy, and he didn't quite get that deep remission and long time off therapy. So some people would say, hey, I don't want to do this again. He's now 72. Can he do the ramp up? Does he want to deal with it? We've got potentially CAR Ts. He's 72. We think that we can push the age limit for CAR T cell therapy. He's been exposed to a covalent and a BCL2 inhibitor. And we also have a non-covalent BTK inhibitor, pirtobrutinib, currently FDA approved. So I think those are the big options, essentially. This is what I talked to you about. There's a new entity, which we really think is agnostic of any certain specific disease feature or molecular feature, and that's the double refractory patient, meaning refractory to a covalent BTK inhibitor and a BCL2 inhibitor. We're actually jumping into a triple refractory patient as the newest set of high-risk patients, and that's those who are progressing on a non-covalent BTK inhibitor. And that's where newer drugs like bispecific antibodies, CAR T cells, and even BTK degraders might come into play to help us there. But nonetheless, you can kind of, like I said previously, go through this algorithm, essentially flipping the regimen, the combination that you started with, and just doing the one that you hadn't used yet. And in general, that's the sequence that we're doing it with patients. But eventually, over a course of a decade, particularly our higher risk patients, they will become resistant to both covalent BTKIs and BCL2 inhibitors. And therefore, we do need new drugs for these patients, because this is why. Now, this is before pirtobrutinib was around, before CAR T cells were around, before degraders and some of these other newer agents that we had readily available. But nonetheless, those patients who are double refractory with CLL had a median survival of about 6 months. So we need to do better. We do better with some of the drugs, but nonetheless, when you see these patients progressing, they're in transformation, and sometimes these drugs that we have to help salvage them, particularly if they've been chemotherapy treated, are not so good at durable remissions, and therefore we still need some help for these patients. So here is just some real world outcomes of patients who had been double exposed and double refractory. CAR T cells gets the highest responses, and not surprisingly, allo is still was used for some of these patients when we didn't have non-covalent BTK inhibitors and we just had PI3 kinase inhibitors. But you can see that the non-covalent BTK inhibitors can do very well. You get responses similar to what we've seen. And the median PFS we know, measured out to 15 to 19 months. PI3 kinase inhibitors and going to chemotherapy after you've been exposed to all these is not going to salvage the patient or rescue them. It's in niche cases that we're still reaching for PI3 kinase inhibitors. They do have some value, I must say, but the toxicity problem, you might get responses, but then you can't keep them on the drug because of the toxicity issues. But they actually are very active in patients who are transforming and kind of Richter transformation type accelerated CLL settings. There is some good data behind that. So we've looked, we being the scientific community, a colleague, Dr. Rhodes, has looked at electronic health records of patients initiating CLL therapy after 2016, which is the approval for frontline BTK inhibitors, followed by BCL2 anti-CD20s. And that associated with the greatest overall survival benefit, that sequence basically. So the use of targeted agents in the first 2 lines of therapy was uncommon in this, and novel treatments were not available to those patients. But this kind of sequence suggested the longest overall survival benefit. And I think we need to continue to reevaluate this with the newer drugs. That was most commonly the most common sequence. Frequently, there's probably less patients there that were getting the ven-O in the frontline setting, which has kind of flipped on its head in the past 3 to 4 years, where we're using more and more fixed durations of the initial therapy. So those double refractory patients, there are a few good options, obviously, still. We have BTK mutations that are being noted. And we have new BCL2 inhibitors that are being developed that actually have described some activity in BCL2 mutations. We have obviously our BTK PLC gamma 2 mutations that are there. And so we need to address these things, because that's the vast majority of these patients who are progressing on these drugs are developing these mutations, rendering these drugs and classes essentially worthless. So what's being explored? Well, time-limited therapy to prevent evolutionary pressure on the drug, on the cell to develop these mutations. We're looking at non-covalent drugs that don't need to bind at BTK CYS481, which is where most of those mutations arise from. We have our immunotherapies, and we have new targeted therapies like BTK degraders that address some of the resistant mechanisms that have been seen. So retreatment with venetoclax is always an option, particularly if you've stopped it and you've had a long-term remission. I am now just starting to retreat some of my initial Ven-G patients that I ever treated on a trial back in 2015. They had a time to next treatment of almost a decade, and I'm now starting to retreat them. So, and they're responding. So you can get responses. These data you have to take with a grain of salt, because a lot of this data is in patients who were heavily pretreated with chemotherapy. And so the second Ven treatment always is less, and these were really high-risk patients at the end. But ultimately, what it kind of shows is that we get CRs, we get PRs, we get 70+% response rates. And that PFS2 is not bad. Many of these patients were on continuous therapy venetoclax because back when we were getting a lot of these patients, that's how we used the drug in the relapse setting as a continuous therapy treatment, as a monotherapy. And while it's good, it's not awesome. I think we can do better, but nonetheless, a median PFS for the second go around of Ven is almost 2 years. So I think that shows that we can utilize these drugs. You can retreat patients. And I think as we're now using these drugs in chemo-free patients, they're going to continue to improve the outcome of that second line therapy. So here's some data with nemtabrutinib, just starting to bring in the non-covalent drugs. Nemtabrutinib, we haven't seen a lot of data from this drug in a long time since it was repurposed by Merck, because they went into just big phase 3 registrational studies, which have not had updates because they're event-driven studies. And so they're waiting for those events to really show any prelim data. Nonetheless, this is old data, but proof in principle that this non-covalent BTK inhibitor can overcome BTK CYS481S mutations. And you could see it works in high risk and low risk patients. Those with del17P obviously have a slightly lower PFS, not surprising. Those with a mutated IGHV can do very well. And then those patients with prior exposure to BTK inhibitors actually can do very well as well. So at the end of the day, no major differences across these groups here, but we need to see more data. It's a very immature data set and small numbers of patients treated. Then we have our pirtobrutinib, which had two big studies. The Bruin study, which put it on the map, basically, a large phase 1/2 that led to its accelerated approval with almost 300 CLL patients treated in the relapse setting. Median was three prior lines of therapy, so patients were coming in fourth line. 80% of them, 70% of them progressed on a BTK inhibitor and were high risk with a lot of these high risk features, and 40% had a BTK mutation. So this is not a good patient population. These are the ones who had 6 months to live essentially after that. And what we saw from the initial phase 1/2 data was that the overall response rate was 80%. Using pirtobrutinib, a non-covalent BTK inhibitor, which is developed specifically to target resistance to covalent BTK inhibitors at the CYS481 amino acid. And the median PFS in CLL was 19 months. So really, really impressive. Overall survival at the 2-year mark was, I think, 70+% or something, and really was an impactful jump forward for our patients. Obviously, when you look at 3-4 years later, almost everybody's come off the drug and progressed. It's not something we're going to see 10-year timelines here, probably, but nonetheless, the worst of the worst patients, these types of patients don't exist because almost everybody on this study actually had chemotherapy. When they looked at, they did a MIAC of venetoclax and pirto to say, hey, well, if you progress on a covalent BTK inhibitor and you've got a choice between venetoclax and pirtobrutinib, which one should you choose? This data is good to look at that, but it's not, you have to take it into context. Most of these patients, again, were very high-risk patients getting venetoclax monotherapy. And we know venetoclax monotherapy isn't that good. It actually works better with the monoclonal antibody added, obinutuzumab. And many of these patients did not get that. So when you look at just ven mono, continuous therapy versus pirto, it looks pretty good. And there's a benefit of pirto being very well tolerated, easy to use, no ramp up, all this kind of stuff. So it kind of proved its principle that it's at least as good as some of the other therapies that we have. And the benefit was that pirtobrutinib is actually very, very well tolerated. This led to the registrational study where pirtobrutinib is now currently FDA approved after one prior line of therapy with a covalent BTK inhibitor, was the 3-2-1 study. This was a randomized study of pirtobrutinib versus idelalisib rituximab or bendamustine rituximab. I think 70% got idela-R, 30% got BR. And what you can see here is that pirto hands down beat idela or BR. And the median PFS at the 12-month mark was around 15 months or something, I think, was being met at around 15 months in this study. A little bit less than what we saw in the Bruin 1/2 study, but nonetheless, very similar patient population, very high risk. And this basically stamped pirtobrutinib for our use and no longer being restricted and relegated to this third line rescue medicine, because there are a lot of use cases. Our 80-year-old patients with CLL, they can't do the venetoclax-oben. They have issues coming in. And so it's nice to say, hey, let's just go keep you in the class, keep you on an easy, well-tolerated drug, and get another 2.5 years out of this, potentially 2 years out of this. So that's where that approval comes in. And what we saw was basically you see BTK inhibitor class effects with pirtobrutinib, though they seem to be very much lower than what we've seen with the covalents. And overall, it's a relatively safe, very safe drug, not just relatively, but a very safe, easy to use drug, 200 milligrams once a day. So Pirto-Ven, you might just say, well, why go to Pirto? Why not use Pirto-Ven? We have Pirto-Ven and Pirto-Ven-R, Pirto-Ven-O. We've got doublets, we got the triplets, we've got data out there. We've now seen Pirto-Ven-Oben in the frontline setting. MD Anderson has run that study showing some of the best outcomes that we've seen. That was presented at ASH this just a month ago or so. But nonetheless, Pirto and Ven seem to work very well together. It does seem to have a lot more cytopenias than we might expect. We're not quite doing this, though. I have done this in practice where, you know, it made sense to do it in a high-risk patient to get them MRD negative and to control their disease as best as possible. But this was some data from Lindsay Roker at Memorial Sloan Kettering. Again, small numbers of patients here, but high response rates, high CR rates, and overall doing very, very well. Here's our CAR T-cell data in the CLL space. This is based on the Transcend 004 study. This looked at lysocell, and this study was the new twist on this was adding ibrutinib into the infusion as well. And so we saw the monotherapy. We saw kind of not great CR rates, 20% CR rates or so. But if you got a CR, you might have been cured. It was the question of how do we increase that CR rate and how do we improve that? Well, one way we do, so this is just the lysocell monotherapy again, and the CR is what you want. That's the blue line, and these patients can have phenomenal outcomes. And we have all heard the stories of 10 and 15 years later, still having transgenes in their blood and still in remission and MRD negative, basically. If you don't respond, you just kind of break through it very quickly. And mind you, only 20% of patients were in the CR. I think it was 40% or so overall response rate. So the vast majority of patients are actually not responding in this curve. There is some disease benefit from getting a PR. You can see the median PFS in the PR group, which is the orange line here, is about 2 years. So that's 2 years off of treatment, a year and a half of treatment. But it is a pretty toxic therapy to be able to go through that. So then they put in ibrutinib during the pheresis, and then for about 90 days post CAR T-cell, there's a lot of data that says ibrutinib modifies the T-cell microenvironment and decreases the exhaustion and improves the CAR T-cell product. It's not being done necessarily to treat the CLL. It's being done to actually treat the T-cells and make them better. And what they saw was that the CR rate did double. It went from 20 to about 45%. The overall response rate doubled from about 40 to 80%. And it seemed to prove its purpose and maybe modestly slightly lower in terms of CRS. So EPCORE CLL-1 is looking at bispecifics in the CLL space. We have a lot of older patients. Maybe not all of them are going to be CAR T-cell, whereas bispecifics off the shelf, pretty easy to use. The CRS is nowhere near as bad. And bispecifics have shown some nice benefit in CLL. So epcoritamab was leading the way in CLL. Actually, I don't think they're developing this drug in CLL any longer, unfortunately, even though they were leading the pack in terms of having the data. It sounds like it was a business decision to do that, and a little disheartened to hear that over at ASH recently. But nonetheless, it's a very effective treatment. Other bispecifics are filling in the space in CLL, and hopefully we will see bispecifics become relevant in the CLL space. But again, high risk patients, high rates of response. So 67% of patients respond. I showed you 40% of patients responded to lysocell monotherapy. only 20% CR rates. Here, 33% CR rates. So I have done this in very rare circumstances in patients, off label, and you have to be very, very careful because the CRS rates were very high, and but nonetheless, I've seen it work, and it is something that I hope we can see others fill in the place of epcoritamab not following through in the CLL space. So here, selecting and sequencing of a third-line therapy, patients, how do prior AEs affect choice? I mean, I think all of these things are going to be relevant in our older patients. We have BTK inhibitor class toxicities that we need to be thinking about. And fortunately, pirtobrutinib gets rid of most of these. It still can cause any of these, but they're at the lowest rates of all the covalent BTK inhibitors. And so even if you are having some of these issues with covalents, you may not actually have them with pirto, and that was one of the first indications was you can use it in the intolerant state. So we have to worry about bleeding, AFib, even ventricular arrhythmias, more maybe with ibrutinib than some of the others. Infections are always a problem here. Cytopenias can be a problem in secondary malignancies. There's a signal out there for secondary malignancies, but it's never really meeting threshold for statistically different than the control arm, despite that control arm still monitoring and following and reporting these. But numerically, it does seem to be a little bit higher in these patients. So we see skin cancer still the most common, obviously, but we are seeing other solid tumor malignancies come out. The lymphocytosis, I don't need to belabor this too much. We see it with all the BTK inhibitors, maybe a little bit less with the second generation drugs. Bleeding, typically it's cosmetic, low grade, 1 or 2, bruising, bleeding. You need to hold the BTK inhibitors if there's surgeries or procedures, colonoscopies, prostate biopsies, teeth pulling. I do it just because it can be bloody and these things can continue to persist, and you want to keep the patient safe, obviously. And then obviously big surgeries, we're holding it 7 days before and typically 7 days after. AFib, we work with our cardio oncologists now. When it happens, I send them over to them. It's not an absolute contraindication to continuing on your BTK inhibitor, but it can be problematic if you've got a debilitated patient and with comorbidities. It can really spin them out of control and then add a whole lot of new medications on top of that. And so it is problematic, but if you can get it rate controlled, and they're not bruising, bleeding by needing the blood thinner, you don't need to stop the BTK inhibitor if it is otherwise working for them, because this is something that many patients have at baseline anyway, and is something that we can typically control and still use. So just note that it's not a contraindication to do it. And as we get to the second generation drugs, we see less and less incidence of atrial fibrillation coming out. Diarrhea, typically an early thing, antidiarrheal medicine. Headaches, maybe more of an acalabrutinib issue, typically goes away. Caffeine, hypertension, got to watch it. It can be sneaky on you, and it's tough to convince the patients that it is in fact the drug, because they always say it's normal at home. And many times they do bring in sheets where it is normal, but I never know what to make of that, because every time they're in my hands, it's 160, 180 over, 95. So we need to watch it. We need to treat it. We need to, intervene, because that can prevent AFib and some of these other things that we know it associates with. Infections are out there. Watch it typically in the first 6 months, particularly in people with burden of disease. Watch the immunoglobulin levels. They can decrease over time, over the years. And the arthralgias can be annoying for patients, and so something we need to help them with. Nausea is not a huge problem with BTK inhibitors. Neutropenia, not a huge problem with BTK inhibitors. Rash, not a huge, typically an early thing, typically can go away on its own, or it's very, very low grade. And again, cytopenias are not that huge of a problem. So when you looked at safety from venetoclax against pirto, again, they match up nicely to where pirtobrutinib essentially looks better across the board of all of these toxicities. And again, another point of doing that study was to say, hey, it's at least equivalent, and you've got better tolerance of it, and therefore maybe making a claim for our older patients, hey, it does make sense to go directly to pirto rather than flipping into venetoclax in this day and age. Here's the monotherapy. Again, the toxicities, 85% CRS.
Grade 3 CRS is 10%. ICANS, grade 3, 20%. And so this is problematic for a lot of our older patients, and we need to do better at preventing this. So I think here's a 72-year-old patient who's doing otherwise pretty well. Higher risk disease, I think, with the P53 disruption. You got to have an informed discussion with him. But I do think, many times patients say, hey, I want to take my chance. I'll come back to CAR T, in a year and a half if this doesn't work. And so, that's what many of them will choose when they're given the two options. So I would say, probably he's now 72. He's got some comorbidities. I would say probably going for pirtobrutinib in this patient. All right, so the last 25 minutes or so, let's flip to mantle cell lymphoma. Here's our mantle cell lymphoma patient. 55-year-old female, diagnosed with stage 4 in mantle cell, and coming in with thrombocytopenia, splenomegaly, GERD, type 2 diabetes, and some peripheral neuropathy. She got hyper-CVAD, which we're not really doing anymore, but we used to, super aggressive treatment, and got a CR, and was consolidated with an auto stem cell transplant. But unfortunately, despite all that aggressive treatment, still relapsed 5 years later. At that point in time, she starts ibrutinib, and then on ibrutinib is now progressing through that and becoming resistant. 2 to 3 years later is kind of what the PFS looks like in this type of setting. So now what do we do for the patient? Well, we know obviously this patient's progressing on ibrutinib, so continuing on a BTK inhibitor is not going to be necessarily what we want to do. But this just highlights kind of where we're moving towards and maybe trying to go chemo-free. So this was a study that was done showing great outcomes for going chemo-free in the frontline setting. We have a lot of data now showing good outcomes going chemo-free with doublets and triplets in the frontline setting of mantle cell lymphoma. We have bovin in highest risk disease. Dr. Ron Giaron, my colleague here, did ALR or acalabrutinib lenalidomide rituximab, showing excellent outcomes 7-8 years later. IMiDs are squared even in the frontline setting. And so we now even have ibrutinib obin ven data, and you can see small numbers of patients here, but even in relapse settings where they haven't seen a BTK inhibitor, using doublets and triplets can really deepen that response, improve that outcome for these patients. And you can see here that group C, which is the treatment naive patients getting the frontline BTK inhibitors. This looks like what any chemotherapy does, and typically these are being given on a fixed duration approach. So pirtobrutinib, obviously, when you look at mantle cell lymphoma, I told you the median PFS for in the Bruin study, Bruin 1-2 study, for CLL was about 19 months. And in mantle cell lymphoma, I think it was like in the 8-month range. So it's definitely a different disease, does not work as well. The total response rate was only about 50% or so compared to 80% in CLL. But if you're in that 50% and you respond, you can actually have very durable remissions, and the median duration of response of those 52 responders was almost 2 years. So these are patients that typically, or they did have exposure to prior covalent BTK inhibitors. And essentially, those patients that respond can do very well. And again, very well tolerated treatment for our patient population. So here is a real-world efficacy of pirto in the relapse refractory mantle cell lymphoma setting, and essentially kind of looks maybe similar in the compassionate use program, actually maybe a little bit better than the pre-treated covalent BTKI patients. Pretty good response rate. Again, small numbers of patients here, but nonetheless, showing that even in real-world patients that aren't the pristine clinical trial patient, we can get these responses, and it mimics that. So we have CAR T cell therapy, and it can get high responses. The duration of response is variable, though there can be some long-term responders. It has some toxicities there. And so right now in the NCCN guidelines, we're really thinking about those who have had covalent BTKI. It's recommending non-covalent or CAR T cell therapy. And I think in mantle cell lymphoma and a younger fit patient, probably I'm looking towards CAR T cell therapy over pirtobrutinib. But nonetheless, pirto is very easy to use, and really we're thinking about all of these drugs kind of together because they're probably going to need all of them anyway at some point in time. So, but here's kind of what our historical standard is if without CAR T. And if you just go to chemo or IMiDs or radiation or venetoclax or whatever it is, the response rates are poor. Bispecifics may have some role here, but the IMiDs and Velcades and the things that we used to use for them before we had pirtobrutinib and some of these other drugs approved, it just didn't work that well. So this is by far and away, in terms of 60% response rate, a 2-year, duration of response, looks a whole lot better than basically, some of these other options for our patients where the overall survival is being measured in 6 months. So our patient had hyper-CVAD progressing on ibrutinib. It looks like she's 60, so she's still potentially a CAR T patient, and I would still consider CAR T. But the problem is kind of the issue is access and ability to get to it, and the lead time and the logistics and all these other things that come into play that make uptake of CAR T still very difficult and not necessarily something that all patients are able to get to or utilize. So there's insurance, financial issues, there's regular, the medical care, where are you receiving it? What is the expertise in that center? Access to screening and treatment, reliable transportation, the culturally aligned health providers, culturally relevant cancer materials, and accessible educational and psychosocial support. So these are all the barriers to getting ideal cancer care. And really, we need to just start to have shared decision making, know that these options are out there, and learn, when is the right time to refer to a center that might have CAR T or advanced clinical trials, testing some of these newer drugs. And obviously, there's a lot of shared decision making models out there. The SMART the SHARE kind of acronym here looks into seek your patient's participation, help your patient explore and compare those treatment options, assess your values, reach a decision, and then evaluate that patient's decision after moving forward. So these things are all out there. When you start a patient on a BTK inhibitor, multidisciplinary team, you need consistent messaging from your pharmacist, your specialty pharmacy, to your physician assistant, to you, to any other navigator within the clinic about what to expect, when to get the drug, how, what side effects you might start to experience early on. You need a lot of counseling. You need a lot of lead time to educate the patient. And then, you need good close follow-up to look for toxicities and assess for response, etc. So continuity of care is the extent to which healthcare services are received and coordinated, including uninterrupted succession of events consistent with medical needs of our patients. There's a strong relationship between continuity of care and reduced healthcare resource utilization. There's been a recent study looking at insurance claims in CLL patients using continuity of care scores, and of these patients examined, 80% of them received the first-line covalent BTK inhibitor. And every increase in your continuity of care score, there were lower odds of emergency room visits, inpatient hospitalizations, total hospitalizations, and lower hazard of death. So educating, starting, and then paying attention to the patient is always important. It's a big team out there that we need to get involved. And this is somewhat seamless, when you put through the script in terms of many of our clinics. But if you don't have some of these pieces in place, it's definitely worth investing in that and building a network. So to summarize here, and we're going to finish a little bit early, so we'll be able to answer some questions. BTK inhibitors are widely utilized in multiple hematologic malignancies. Covalent BTKIs are safe and effective. The non-covalent BTKIs overcome resistance to our current armamentarium. All BTKIs have similar expected side effect profiles, though there are differences that we are all pretty well aware of between the ibrutinibs of the world and the second-gen drugs, and even now non-covalents like pirtobrutinib. Shared decision-making is so important, particularly in the CLL space, where you have a lot of time to make decisions.
and ongoing patient education is so important into improving outcomes for our patients. So here's our SMART goals for today. We want to incorporate that latest trial data, improve management of potential AEs, and provide that ideal patient care. That's what our goals are, and that's what CEC Oncology is trying to do out there for all of us. So thank you. We got through it. There's a lot of data. It's an older deck. These things get outdated real quick when you have a big conference like ASH coming up, and so, but nonetheless, it's there, and we can talk about it. If there's something you saw or some questions you might have or issues in the clinic, please put some questions in the chat. Otherwise, get your CE credits, and I will put the information there. Okay. Thank you for your time and attention. I did see some questions in the chat, maybe. Oh, yeah. I'll hang around for a few more minutes. Please get your credits though, for sure.
Dr. Allen, the questions, if you click on more on the bottom of your screen, you'll be able to see the Q&A box.
Oh, how do I? Oh, more. There it is. I see. I'm missing those. Great. Yeah, so great question. The first one here, what is the potential of Pirto as a first-line BTK inhibitor? So at ASH, there was a late breaker in the CLL space, and that's really where they've gone frontline. It was against bendamustine rituximab in the frontline setting. And they also at ASH showed a study against ibrutinib with a cohort in the frontline setting, Pirto versus ibrutinib. So one true registrational against chemotherapy, one against ibrutinib to kind of support that package and convince people that, hey, this is a good drug. So, I mean, it looks good. And I do think there's going to be a lot of use cases for using pirtobrutinib in the frontline setting. I think people are still a little bit hesitant to jump on the train, even though, you know, kind of no brainer, hey, this drug is equivalent, but it has potentially less side effects. That's how the second generation drugs became standard of care over ibrutinib. I think with Pirto, it might be a little bit less of that. One, our second generation drugs are pretty well tolerated. Two, the resistance panel profile to pirtobrutinib is a little concerning. So we didn't really talk about this, but those resistant patterns to pirtobrutinib show that there are BTK mutations developing that might render other covalent drugs ineffective. So while we currently have covalent to non-covalent as a potential sequence and have proven that that works, we have not quite proven that non-covalent to covalent works. And the data would suggest that it won't work. And so I think that question is lingering in people's heads, and it's going to be, I think, one hesitation for people to say, I want to use pirtobrutinib in the frontline setting, particularly for like your 60-year-old patients that's got 30, 40-year horizon that you want to get them through. But with that said, I think with data maturity and maybe showing low rates of mutational development or only occurring in the highest risk types of patients, maybe we will start to use it more. I do think we will probably start to use it more and faster than we think we will. But I think those are the big impediments to do it. The other thing that might speed its potential to be used in the frontline setting is using it in combination as fixed duration, where you release that evolutionary pressure to develop resistant mutations, and therefore you can keep just using it years in advance and just retreating patients over and over again. And I think if you can spare toxicity and maybe use the best combination drug, which right now the evidence might suggest that Pirto and Ven and Oben might achieve the highest rates of MRD negativity in CLL. I see a lot of potential that we can jump on the train real fast because I do feel like we will not develop resistance in these fixed duration approaches. So that's where it's at. But yeah, I think we might see approvals in the near future. There are probably going to be these use cases of, you have an 85-year-old, you basically are not looking for 30 years to get a patient through, and you're looking for something, maybe a 5 or 8 year horizon potentially, and you just want the best tolerated drug that's going to control their disease for the longest period of time. And I think in that's where we're going to start to use it a lot really early on, should it get approval. But until then, or has some indication, I've been holding back, and but I do think it will get there. So very good question.
And I filled you in on some of the latest data from ASH. So hopefully you're aware of it and definitely look into it if you aren't. There's another question. How do you ensure continuity of care at your institution? So yeah, I mean, it's a good question. You know, I think we will send our patients to follow up and force them to get an appointment, basically. I have no idea. You have no idea how many of my times I send a patient to a cardiologist or a nephrologist or a neurologist or rheumatologist. And I say, so when are they seeing you back? They're like, oh, I don't know. I left without an appointment. And the note will say, see back in 6 months. And it's just like to leave patients up to say, you got to schedule it. You got to remember to come back. It doesn't make any sense that these patients are not leaving with an appointment. I mean, I leave my primary care doctor without an appointment. I have to do it myself. So I think that's one thing. We are very strict about saying you leave, you're going to schedule your appointment now. I think most oncology clinics are probably like that because we do need to be so invested and make sure that patients don't fall through cracks. One is utilizing your pharmacy, our specialty pharmacy. We have an in-house specialty pharmacy. They will call patients for us and make sure at 2 weeks after starting the BTK inhibitor or the venetoclax or whatever it is that they're calling them to check in on their side effects and giving them patients an outlet to state things and where they might be intimidated to tell a doctor something. You have no idea how many times our pharmacist is messaging us, hey, Mr. So-and-so is stating that they feel this, or they have diarrhea, or they have a rash. They were interested in receiving a call back. So there's a lot of that. Our social work is involved a lot with our patients and support groups, etc. So I think all of these little things help. But you do need to put effort into doing it, and you do need to see patients back. I think some patients get seen back too soon and too often. CLL patients, you don't need to see back constantly every month or every 6 weeks. Typically it's every 3 to 4 months. Some I see 6 months, some I see once a year, honestly, if they have really low risk disease and have been very stable. So they can do very well and they know, and if they're seeing a primary care in between, you're going to get CBCs and you're going to see changes and they can call back sooner if they need. So that's how we do it. Hopefully that answered the question potentially. And then another one, if nimtabrutinib were to approve, how do you compare it to Pirto? Great question. I think we need to see the NIMTA data. I think one differentiator is that they may have a different toxicity profile. They may have a different resistance profile. They may be able to prove that NIMTA could work in some of these Pirto resistant patients. And so there's still a lot up in the air. Obviously, Pirto has a leaps and bounds head start. It's already FDA approved. People are getting into their prescriber habits. They're getting used to how the drug works. It's out there in combination with everybody. So, I mean, I think it's going to be a hard drug to topple in terms of use because it is so safe and well tolerated and 2 pills once a day. But I do think there's always room, and I don't think we know everything, and there's always chinks in the armor to potentially start to get into and start to wedge apart potentially for these new drugs coming on, and they find their niches sometimes. So I think we need to see the data mature. We just need to see data. We haven't seen data in a long time, many, many years, honestly, because they went really big with these big phase 3 clinical trials, and we have not seen a lot of updated data. But I think that story needs to be told. So I don't have that answer for you. Another question here, in MCL, what sequence of covalent, non-covalent inhibitors, CAR T cell, Ven bispecific would you use and why? Yeah. So, I think I'm typically using covalent BTK inhibitors kind of in that second line setting. With venetoclax, in the high-risk mantle cell lymphoma patients, I am going chemo-free. I follow the NCCN guidelines. I'm using Boven a lot for these types of patients. I do think we should start using, even in lower risk mantle cell lymphoma, just chemo-free approaches. I don't think we need the BR with the Acala. I don't know if it's adding much. We haven't done that study where we've done Acala BR, Acala, and then just BR to see what the additive effects are. But I'm suspicious that Acala is kind of doing all the hard work. So I do think these lower risk patients can probably go chemo free. In general, I'm using covalent BTK inhibitors. And the story with venetoclax is that it's not a good drug as a monotherapy in mantle cell lymphoma. So I think we're going to get into the era, particularly when we start to use these drugs in the initial frontline setting, where you use Ven as the first line drug, because holding it for a salvage down the line or some sequence probably doesn't make as much sense in mantle cell lymphoma as it does in CLL, where you can get MRD negative and you can use it as a monotherapy with an antibody and get really good responses. Here, it really seems to be a partner with a BTK inhibitor. And as that data matures, we're probably just going to say, when you're using a BTK inhibitor, you should probably be using the BCL2 inhibitor, honestly, in mantle cell lymphoma. With CAR T, I do think it's got value there. I think there are newer products coming out that might be a little bit safer and better tolerated potentially. Nonetheless, it has some good activity and long-term durable remissions. So I'm reaching for it. Now, the question is, with bispecifics coming in, how do you sequence the bispecifics or CAR T cell? I think that's a valid question. And I think that's a question not just in mantle cell lymphoma, but in all lymphoma, where we have these drugs and CAR T cells. I do think when you look at CAR T cell and pirtobrutinib, they did a MIAC. I showed you some of these MIACs, match adjusted indirect comparisons to CAR T cells. And actually, it did look like CAR T cell provided a better outcome. So if you do have a CAR T cell fit patient, I do think it's valuable to use that window of opportunity and jump towards the CAR T cell rather than trying to go to Pirto, and you might only get 6 months or maybe a year out of it. And then, the patient might be sicker and maybe that window for CAR T closes. So I do think it is something that we should offer our patients, that I think all mantle cell lymphoma patients in this day and age, particularly since they're usually a little bit younger, should get in their treatment. Whereas in CLL, I don't know if they need CAR T, honestly. And I'm using it for a very select type of patient population. It's an also older population. So I don't know how to answer the question, but I think you can glean it from what I was stating. In general, though, if I am going to use chemo like BR or something, I am typically adding in the BTK inhibitor. I haven't used the triangle regimen in a long time. I haven't quite found that right patient for it. But I do think that data is pretty good, and it's hard to argue if you want to eliminate stem cell transplant for the patient. It's hard to argue that you do anything else because that's where the data is. So I do think I am incorporating the drugs into the frontline setting. I'm trying to incorporate more and more into just chemo-free incorporation in mantle cell lymphoma. And then that sets the sequence up for you a little bit nicer down the line. Hopefully that made sense. How do I decide to use Pirto in the first line setting? Yeah, developing those BTK systems. So I alluded to it a little bit. I guess I'm still in the camp where I want to see longer term data, and I want to see what these resistant profiles look like in high risk patients in that frontline setting or in the relapse setting. Just really, I mean, we already kind of know what that looks like. So I'm not ready to jump and use it, but if the combinations come around, and it's hard to argue that PVO is better than ZVO or AVO or whatever it is in terms of MRD or some outcome, then I could see myself adopting it pretty quickly. But I want to see that data mature a little bit. I want to see long-term outcomes. I want to see MRD data. And right now, I might just be using it should there be an approval in that frontline setting, kind of for that 85-year-old patient, like I stated, where you're really looking at 5, 6, 7-year horizons rather than 30, 40-year horizons to use that drug in the first line. But I can be convinced. I think we will surprise ourselves and be using it more and more than we think, probably sooner than we think. Any recommendations for managing CRCI in older patients? Any recommendations for eradication? I don't know if that means creatinine clearance or if it means CRS. Yeah. I think, I don't do a lot of CAR T cell therapy myself. I do outsource that to my cellular therapy colleagues. I think they are getting more and more aggressive with utilizing TOSI and preemptively, et cetera. And with the bispecifics, we aren't quite to the myeloma space to, where they're throwing TOSI at people even before giving them their bispecifics and throwing IVIG at all these patients. We aren't really doing that in lymphoma. At least I've talked to a lot of colleagues. It seems like they haven't really adopted that yet. Maybe it's because it's a different disease state. But, I think you can be loosey-goosey with the TOSI out there if you've got an older patient. Many trials now in our 65 and 70-year-old patients, even for grade 1 CRS, are sometimes recommending to start the TOSI for some of these patients. So, typically we do it for grade 2. It's not wrong to do it if you've got access to prevent things from really spinning out of control in our older patients who don't have a lot of reserve. And so I think that's where we are a little bit more liberal in terms of aggressively managing any CRS that starts. Do I check MRD and mantle cell lymphoma to determine the transplant? So I don't use the MRD to determine the transplant. In fact, most of the data would say that even if you're MRD negative, you still benefited from maintenance rituximab and maintenance transplant. So MRD is not necessarily something that's helping guide treatment in mantle cell lymphoma. Trials are established to de-escalate therapy if you're MRD negative, et cetera. I do check it. I like MRD. I use it. I think it's information that we can get. It gets covered for the most part. And why fly blind? I mean, we're physicians and we're in a tough place where, information is power and it helps guide and prognosticate and, help understand a disease process. And so I think why not use the tools at our hand? So I do use MRD. I don't necessarily use it to determine to transplant or not. I think even if you're MRD positive, there's still benefits for proceeding with these maintenance treatments. All right. I think I got through them all. So, all right. Thank you so much for your time and attention, and I appreciate you guys hanging around for this. All right.
Thank you and have a great evening.
Thank you.